Hey everybody, today I want to share with you an ECG from a little puppy. This is a 7-month-old male French bulldog. And looking at our ECG, we have 9 leads, and those are in the top 3 lines, and lead 2 all along the bottom. The entire trace is at 25 millimeters per second. And so looking at our heart rate, it's just shy of 150 beats per minute. We do have a rhythm that looks fairly regular. There's a P for every QRS and a QRS for every P. The P QRS distance or PR interval looks very consistent. So I think those events are associated, and the Ps are positive in lead 2. So rapid assessment of what I think looks like a normal sinus rhythm. I think the interesting part of this is in fact related to the QRS morphology and the mean electrical axis. So let's chat about that. So recalling, how do we do that mean electrical axis activity again? Number 1, we look in the frontal plane leads. So 1, 2, 3, AVR, AVL, AVF. And I like to use the isoelectric method. So I'm looking first for my most isoelectric lead. So the lead with the QRS complex that the positives and negatives are closest to 0 or cancel each other out the most. And so I'm picking lead 1 here as my most isoelectric lead. Then I need to look at my frontal plane diagram, and here it is. Again, think of this as sort of a DV radiograph. That's the plane we're in. And I need to select which lead is perpendicular to that isoelectric lead. So looking at my frontal plane diagram, I see that AVF is perpendicular to lead 1. So when I look at AVF, now I have to examine the QRS complex in that lead and ask myself, is the QRS complex more predominantly positive or negative in orientation? And the QRS complex in AVF is more negative. So the mean electrical axis is roughly pointing in the vicinity of the negative pole of AVF. And I've put a large purple arrow there to show which direction that is, the negative pole of AVF. And if we recall, that's sort of exactly opposite to where the mean electrical axis typically points. We know it usually points down in the region of the positive poles of lead 2 or AVF. So what we can say here is that we most definitely have a shift of our mean electrical axis to the right, or a right axis deviation. And let me just go back one for a moment, a little trick. If we want to know sort of on what side of that purple arrow we might be, we can look at leads that are equidistant from that. So equidistant from that purple arrow are AVR and AVL. And if I look at my ECG in AVR and AVL, the QRS complex is more positive in R compared to AVL. So I'm on the AVR side compared to the AVL side of that purple arrow, if we want to get a bit more detailed. Nevertheless, the MEA is pointing to the right, which it shouldn't, also called a right axis deviation. So what are my differentials for that? Well, you may recall from a couple episodes ago, we talked about right bundle branch block. And so one differential certainly is a right bundle branch block when my MEA is pointing to the right ventricle. But typically with that disorder or that conduction disorder, the QRS is really wide because we've sort of lost that superhighway normal conduction. And there's a lot of cell-to-cell slower conduction happening in that scenario. And it makes the QRS really wide. Right ventricular enlargement is another consideration, and it doesn't tend to produce as much widening of the QRS. So in this little puppy, that's sort of maybe where I'm thinking more so. I would rank right ventricular enlargement perhaps higher on my list of differentials than a right bundle branch block. And in a puppy, I might start to think about, well, what disorders could give me a right ventricular enlargement pattern? Things like pulmonic stenosis, for instance. So hope that little mean electrical axis activity helped you yet again, and we'll see you next time.